So with the passage of H.R. 1, the 2025 reconciliation law, which includes significant reductions in federal Medicaid funding, states are already making, and in some cases, accelerating policy decisions that may limit or eliminate access to HCBS. These decisions are happening right now, often quietly through mechanisms such as enrollment caps, spending limits, service reductions, and waiting lists. Um, it's imperative that people with disabilities, families, advocates, and policymakers understand these policy tools and their real world consequences and the way that they roll down to programs and services. Today's webinar will help ground that understanding, and our discussion will cover an overview of changes to Medicaid stemming from the 2025 reconciliation law and what those changes mean for state budgets, an overview of Medicaid home-based care with an emphasis on why home-based care and HCBS are particularly vulnerable to cuts, a closer look at how states are currently managing home care spending and how these strategies could expand as states address growing budget pressure related to Medicaid cuts across the country, to councils on developmental disabilities, and how councils on developmental disabilities are actively engaged with state Medicaid directors, legislatures, and other partners as H.R. 1 moves into the implementation phase. This report provides crucial insight into the challenges states are facing, particularly as some consider reducing home and community-based services due to the downstream impacts of the law. I've already shared this report with our NACDD network, and there's strong interest in learning more about the findings and applying them to ongoing state budget negotiations happening now and continuing into early next year. We see this analysis as a vital tool for informed advocacy and for helping councils and our partners ask better questions, anticipate risks, and push for policies and programs that protect community living. Even though many of you have read KFF's report, today KFF will share with us new and unpublished data. I am very interested to hear this piece, especially. I've read the report. It's extremely interesting. It's extremely applicable. And the new data that isn't in that report is exciting and interesting, even more interesting to me. So some housekeeping, always got to do that. Although we have disabled the chat function, we do encourage you to use the question and answer function to ask any questions that you might have of Alice and Mace today. We will have questions at the end of KFF's presentation. We clearly will not get to all of them. We might get to 2 or 3 or 4, but we will allow some questions to be answered. There is a button at the bottom right of your screen to turn on captions. There are options to have the text at the bottom of your screen or on the right side. And if it's on the right side, you will see the current and past text of this event. So you'll get to go back in the text and see what was said previously. If you need that option, you're going to want to choose that option. And lastly, out of respect and to honor the request of our guest, KFF, we ask that no recording or screenshots are made of this event, no photos of what you will see. KFF will publish their new data in January, but we are getting to see it now. So we need to be respectful of that, grateful for that, and not screenshot, not record, not take photos. NACDD will send out meeting transcripts after KFF's report has been published in January. So please be respectful of that. With that, I am pleased to turn it over to Mace Mohammed and Alice Burns from KFF to walk us through their findings and what they signal for what these findings signal for the future of Medicaid home care and HCBS. Thank you both for being with us today. And Eric, can you make sure that they are unmuted?
And were you going to share the slides or did you want us to? Oh, perfect. Thank you so much. I am delighted to be here. I really appreciate your having us to talk about our new research. And just to give you a little sense of how the presentation will go, we're going to start by talking about, next slide, please. The changes that the 2025 reconciliation law made to Medicaid will keep it pretty high level and try to focus on the things that are most relevant for Medicaid home care, also known as HCBS. Then we'll talk about what Medicaid home care is and why it's so vulnerable to Medicaid cuts. Lastly, we'll talk about the unique tools states are leveraging to manage spending on home care and how those may relate to this whole debate about Medicaid spending. Next slide, please. I just want to take maybe 1 minute to talk about KFF. If our organization is new to anybody on the call, we are KFF. We used to be known as Kaiser Family Foundation, but we are not a foundation and we are not affiliated with the Kaiser Health Plan. So for that reason, we switched to just KFF. All of our data and information are free of charge. We do not accept federal funding. We are a nonprofit organization that is just dedicated to providing nonpartisan information on national health issues. Really key here, we don't make recommendations. We don't endorse specific policy proposals, say this is good policy, this is bad policy. We do data, and that is data and analysis is pretty much it. Next slide, please, and then we can go to the substantive one right after. Thank you. So the Congressional Budget Office estimates that the 2025 reconciliation law will reduce federal Medicaid spending by $911 billion over 10 years. And that is a historically large reduction in federal spending for Medicaid. Over half of those spending reductions, those in the blue boxes, only apply to states that have expanded Medicaid. And I say that up front because the significance of this law depends a bit in what state you're in. And if you're coming from an expansion state, the effects are going to be more profound. The single biggest source of spending reductions is work requirements, and these only apply to people who are eligible for Medicaid through the Affordable Care Act Medicaid expansion, and people who are eligible through that group are going to have to meet new work and reporting requirements. The other big changes that only affect expansion states are reductions to provider taxes. We'll talk a little bit more about those later. And then more frequent eligibility redeterminations for Medicaid expansion enrollees. Turning to the green boxes, those are policies that affect every single state, regardless of whether or not they've expanded Medicaid. The biggest one there is these new limits on state-directed payments. We will talk about those a bit more. Those are primarily cuts to hospital payment rates. The eligibility rule, this is a case where what the reconciliation law did is it's delaying by 10 years implementation of Biden-era eligibility rules that would have made it easier for people to qualify for Medicaid and keep their Medicaid coverage. Those changes really disproportionately would have helped people who are eligible for Medicaid because they're older adults or have significant disabilities. And so what we're expecting is fewer people to be coming into Medicaid through those pathways because of the delay of the rule. That does not mean people with existing coverage are going to get kicked out, however. Finally, all states are unable to increase provider taxes or enact any new ones. And really that matters because it restricts states' ability to respond to these federal cuts in spending. And we'll talk a little bit more about that. Next slide, please. Looking at the data, 6 in 10 adults on Medicaid are already working, and many others are likely to qualify for an exemption from the work requirements. However, these work requirements are estimated to save Medicaid $326 billion. And those savings come because people are going to lose coverage. Some may lose coverage because they don't comply with the requirements. Others are going to lose coverage because they don't comply with the paperwork. One of the things, this really varies by age group. And so among adults who are under age 50, over 2/3 are likely to meet the requirements because they are either in school or working. However, fewer than half of adults ages 50 to 64 are in that situation. And so the paperwork requirements and meeting the requirements may place a bigger burden on older adults, those ages 50 to 64. Next slide, please. The second largest source of federal Medicaid changes are changes to provider taxes. So I'm going to apologize right now because provider taxes are wonky, they are complicated, and they're really difficult to talk about. However, of the Medicaid cuts, these are probably one of the most relevant policies in the area of home care because what's happening here at the highest level is the federal government is restricting states' ability to raise revenues to pay for Medicaid. So let's unpack that a little bit. States use provider taxes to fund the state share of Medicaid spending, and these taxes are permissible under federal law within certain limits. What the reconciliation law is doing is establishing new limits on these provider taxes. In all states, they can't expand provider taxes. They cannot establish new ones. And the reason that matters so much is over time, provider taxes have been adopted when states go through recessions, when states have reductions in their income tax revenues, when there is an increase in the number of people without health insurance, and providers are trying to stay afloat. What states have done is they've used these provider taxes to maintain Medicaid spending when they otherwise might not be able to do so. And so by prohibiting states from establishing new taxes or from increasing the rates of existing taxes, this really just limits states' ability to respond to everything else that's happening in the reconciliation law. The green states are Medicaid expansion states that are also going to have to reduce their provider taxes to comply with new limits that only apply to expansion states. And so in those cases, it's not only that the states can't raise new revenues, it's that they're going to have to reduce existing ones. Next slide, please. And then the other big component of these spending reductions is limits on state-directed payments. And this is state-directed payments happen when the state tells Medicaid MCOs how to pay providers. In nearly all cases, these are used to pay hospitals, though a handful of states may have state-directed payments for nursing facilities or home care providers. And prior to the reconciliation law, states could establish payment rates as high as average commercial rates. The thinking here was this would help make sure access to care for Medicaid patients was similar to access to care for private pay patients. Under the law, the payment rates are going to be capped at 100% of Medicare rates in expansion states and 110% of Medicare rates in non-expansion states. This is primarily a cut to hospital payment rates, though again, some other providers may be affected, and it's basically going to require hospitals to provide the same amount of care they're providing now, but just get less payment for doing so. A lot has been, next slide, please. We've heard a lot about rural health care, and there is this Rural Health Transformation Fund. Everyone is waiting for the announcement of the state allocations, which is expected by the end of this month. And that's $50 billion in new funding that's going to the states to help support health systems in rural areas. The challenge here is that we estimate $137 billion of the Medicaid cuts could be felt in the rural areas, and that's a lot more than what's coming into the system through this Rural Health Fund. Next slide, please. So if we think about the size of these cuts, there's sort of two different ways we could think about it. One, we could think about these cuts relative to federal Medicaid spending. And so on average, across all states, the estimated federal Medicaid cuts are about 14% of what we think the federal government would have spent had the law not passed. And so that's sort of the map on the left-hand side. And what you could see is these dark blue states are the states that are going to be really disproportionately affected in terms of the volume of dollars that are coming out relative to the size of their Medicaid program. Turning to the right-hand side of the state, we also tried to think about this relative to state budgets. How big of a deal is this relative to what states are spending? And so in an average year after the cuts have taken effect, these cuts amount to 10% of all federal funding to states. They amount to about half of what states spend on the education and well over the entire amount that states are spending on corrections. The real challenging thing states are going to have to contend with is that these cuts are coming on top of other cuts to federal payments, particularly in the areas of agriculture and education. Next slide, please. Another co-occurring challenge is the workforce situation. As we all know, there is a shortage of home care workers. This has been true since before the pandemic. It was exacerbated by the pandemic, and recent immigration policy has further exacerbated this challenge. 1 in 3 of home care workers are immigrants. And so when we have a reduction in immigrant, that is going to place further downward pressure on the workforce. Next slide, please. And then lastly, this is all happening at a time that we have a rather unprecedented increase in the number of people uninsured. If we think about the effects of the expiring ACA tax credits and the reconciliation bill together, the Congressional Budget Office estimates that once everything is implemented, that is an additional 14 million people without health insurance. And what you can see here is the percentage point increase in the state's uninsured rates. And what's interesting is some of the states are the same states that are really heavily affected by the Medicaid cuts, but in other states, most notably Florida, this ACA change is going to be putting a lot of pressure on state budgets, independent of what's happening in the Medicaid space. Turning to the next slide, please. So sort of putting all this together, the reconciliation bill did not restrict or limit home care spending in any way, but it is very likely that there will be effects on people who use home care. First of all, over half of the savings are coming from reducing Medicaid enrollment to the extent that these are people who have disabilities, who are using home care, they will no longer have Medicaid. In future years, the home equity limit for people who use long-term care is going to be reduced to $1 million. That's regardless of inflation. Over time, the effects of that new home equity limit are going to continue to grow. The bill also provides additional funding to ICE, further amplifying the effects of recent immigration changes. And so we think there's going to be a lot of pressure on states to reduce federal spending. And so we can turn to home care and why we think that is particularly vulnerable. Next slide, and then next slide. What this figure shows is the percentage of all long-term care spending in the United States that comes from Medicaid. And the dark green segment at the bottom is Medicaid's share of spending that goes to institutional care. And what we see is that's actually been dropping over time. The lighter green segment is home care, and you can see how much that's grown. And the reason, I'd like to start here is it shows a couple of things. First, Medicaid pays for 60% of long-term care in the United States. That is a really big deal. And Medicaid's increasing coverage of these optional home care services has really resulted in the home being the #1 place most people are now receiving their care. And that is a pretty big shift from Medicaid's history, which was initially created with what has been referred to as an institutional bias. Next slide, please. When we look at this slide looks at the percentage of people who use Medicaid long-term care in each state who are receiving their services in home and community-based settings. And what we see in these dark blue states, over 80% of people using long-term care are receiving those services in their homes, not in an institution. For the lighter blue, it's 60 to 79%, and then it's less than 60% in the 9 green states. Even so, if we think about the fact that historically Medicaid started with just a nursing facility benefit, it's really remarkable how widely states have embraced these optional services. Next slide, please. The risk here, though, is that these services are not inexpensive. And if you look at the left-hand bars, this is the percentage of enrollees. The right-hand bars is the percentage of expenditures. And so 21% of Medicaid enrollees come in because they are 65 and older or have a significant disability. Again, fewer than 1 in 4 enrollees. However, those 21% of enrollees account for over half of Medicaid spending. And the difference is they use more acute care, but they also do use more long-term care, and that is not cheap for states to provide. Turning to the next slide. This slide shows which long-term care benefits are mandatory and which state benefits are optional. The mandatory list, really easy. It's nursing facility care, home health, that's it. Everything else is provided at state option. And so that would include intermediate facility care and then a wide array of home and community-based services or home care. And there's really two sort of buckets of these home care services. The first are state plan benefits. And those are kind of similar to other Medicaid benefits in that the state makes them available to everybody in the state, generally statewide, with some exceptions. Waiver benefits are fundamentally different. Waiver benefits allow states to create custom tailored benefit packages unique to specific populations. They can offer different services in different regions to different types of people. One of the strings that comes attached with these programs is the states have to show the federal government that these are cost neutral. And by that, it simply means the state has to show that offering these services is not going to cause the state to spend more than if the person was served in a nursing facility. And when states establish these waiver programs, they have all sorts of tools they can use to demonstrate cost neutrality. They can establish caps on the number of people who are served, caps on total spending. And the reason this is so important to be aware of is states can change these things often administratively. And that's not something states can do for other benefits. For other types of benefits, either they're required to offer them, or if they want to change them, they have to eliminate the entire benefit. They don't have the ability to just dial it up and down the way they can with waiver services. So I'm going to turn it over to Mace, who's going to talk a bit more about the waiver services and our data about how states are covering these waiver services.
Thank you, Alice. And as Jill mentioned at the beginning of the call, I just want to reiterate that a few of the next slides include data that have yet to be released. So we just ask that you do not cite or reproduce any of the slides with this red text on it. And those issue briefs will be published in early January. So you should be able to access them really soon. So in 2025, states operated over 300 different programs for Medicaid home care, many of which targeted a specific population. And as you can see here, the most common waiver programs target people with intellectual and developmental disabilities and people who are ages 65 and older or who have physical disabilities. And states also serve other populations, such as people with mental health needs, medically fragile children, or people with traumatic brain injuries. And a few of the less common programs serve people with HIV and AIDS and people with autism. And states can also offer multiple waivers for each population. Next slide, please. Another key feature to waiver programs is how states can really custom design and tailor the benefit packages to meet the needs of the target population. So here we focus on waivers for people with intellectual and developmental disabilities and those for older adults or people with physical disabilities. And what we see is that all states with intellectual and developmental disability waivers offer supported employment at the top of the figure in at least one of those waivers. But few states offer supported employment as a service through their waivers for older adults or people with physical disabilities. And there may be less of a need for support with finding and maintaining employment among adults ages 65 and older, because as you can imagine, they are often retired. On the opposite end, if we look at the bottom here, home delivered meals are more likely to be available through the waiver serving people ages 65 and older and those with physical disabilities, which is a group that may have functional needs and would benefit from a meal delivery service. So these are just a few of the ways that states are really tailoring the waiver programs to the needs of the target populations. Next slide, please. And if we look at the three most commonly covered services for waivers serving people with intellectual and developmental disabilities, we can also develop a better understanding of how exactly states tailor the waiver services to the needs of waiver participants in a specific population. So in the green, we see supported employment, as I mentioned before. This is covered by all states, all responding states that offer intellectual and developmental disability waivers. And supported employment is any assistance that helps a person find or keep employment or pursue self-employment. And there's several activities that can go under this service category, but a few include help with developing a plan to find employment or accessing the needed workplace accommodations to help someone in a role that they currently have. And in the middle, there's equipment, technology, and modifications, which is covered by 46 states. And these are any material goods that help a person improve or maintain function. And these can vary greatly based on the needs of a specific waiver participant, but some examples include installation of a wheelchair ramp or modifications to a bathroom or vehicle for accessibility purposes. And then lastly, in the purple, 42 states cover home-based services. And these are services that support a person who does not have or are provided by a provider that does not have round-the-clock responsibility. These are primarily provided in a person's home, and some examples of direct care workers that provide this service are home health aides and personal care attendants. Next slide, please. States also use optional Medicaid benefits to support family caregivers. And here we focus on a specific instance where states actually pay an hourly salary to the family caregiver who supports a person with an intellectual and developmental disability. And as you can see in this chart, among the 47 states with waivers for this target population, most allow payments to any family caregivers. So either legally responsible relatives and other family and friends. And then in the light blue, less than a quarter allow payments to only other family and friends. And legally responsible relatives include spouses, parents of minor children, and other caregivers. And beyond paying family caregivers, states use other tools to help family caregivers, such as covering respite care, which pays for professional care to help allow family caregivers to take breaks as needed, offering training and support groups, or through structured family caregiving, which is a benefit that provides family caregivers with professional support and a daily stipend to assist with their caregiving duties. Next slide, please. States can also use waiting lists to track and manage people who want to receive home care but are not yet receiving it. And in 2025, 41 states maintained waiting lists for home care, and there were over 600,000 people on either waiting or interest lists. And states put people on waiting lists when the number of people seeking services exceeds the number of waiver slots available. But it's important to note that these lists are not a measure of unmet need. If states don't offer the benefit, there is no waiting list. So that sort of shows you one way in which one reason in which we cannot use the list to measure unmet need. And most people, close to 2/3, close to 3/4, excuse me, on waiting lists or interest lists have intellectual and developmental disabilities. And most live in states that do not screen any people for eligibility prior to adding them to waiting lists. And the remaining nearly a quarter of people on these lists, which is in the green here, are adults ages 65 and older, or people with physical disabilities. And states also use waiting lists very differently. Some use them when the waiver is at capacity in terms of spending, in terms of enrollment or spending. However, other states use them when there are provider shortages. And in states that don't account for provider availability, people may get off a waiting list only to find that there are no providers available to see them. Next slide, please. So now I'll talk a little bit more about the unique tools and mechanisms that states are using to manage spending on Medicaid home care and how they're doing that in state fiscal year 2025 as well as state fiscal year 2026. Next slide. Thank you. So states use a number of different mechanisms to limit Medicaid spending on home care in state fiscal year 2025. This figure shows the number of states that reported any of these caps or limits for at least one home care waiver among the 50 states that responded to the survey. And we look at these caps in two broader categories. The first being caps on waiver spending or enrollment, and the second being limits on the services that waiver participants can use. And we see that nearly all states have caps on waiver spending or enrollment in place and limit the waiver services that participants can use. And as you see in the figure, the most common limit in place among responding states is spending on specific types of waiver services, whereas caps on total waiver spending are the least common. Next slide, please. So here we look specifically at the caps on waiver spending and enrollment that states have in place for waiver serving people with intellectual and developmental disabilities and adults ages 65 and older or who have physical disabilities. And the use of these caps is similar across both target populations, as you can see. Among the 47 responding states with intellectual and developmental disability waivers, 37 had caps of some sort, including only 8 with caps on total waiver spending, 27 with caps on total participants, and 26 with caps on spending per waiver participant. And then in the green, you can see that for the 45 responding states with waivers serving adults ages 65 and older or those with physical disabilities, 33 had caps of some sort, with only 6 having a cap on total waiver spending, 28 with caps on total participants, and lastly, 22 with caps on spending per waiver participant. Next slide, please. Most states also limit the use of home care services per waiver participant, and states are more likely to use spending caps for waivers that serve people with intellectual and developmental disabilities, but are more likely to use specific service limits for waivers that serve older adults and people with physical disabilities. Of the 47 states offering waivers serving people with intellectual and developmental disabilities, close to 2/3 of states cap spending for waiver services per participant, and nearly a third limit personal care hours or visits per person. And then for the 45 states with waivers serving people who are ages 65 and older or who have physical disabilities, limits on the quantity of personal care are more common than caps on spending for waiver services per participant. And states reported capping a wide range of different waiver services, but some examples include caps on home and vehicle accessibility modifications and adaptive equipment and assistive technology. Next slide, please. We also asked states which, if any, cost containment strategies they have adopted for use in state fiscal year 2026. And it's important to note that states generally completed the survey prior to enactment of the reconciliation law. So changes to limit spending that they reported in fiscal year 2026 are not attributable to the new law. 15 states, though, reported new caps on waiver spending or enrollment or service limits for any home care waiver. And a few states reported planning to adopt more than one mechanism, 8 states, for any home care waiver. And if we think about these caps within the broader categories I mentioned earlier, we see that 11 states reported planning to adopt new mechanisms specifically to limit waiver enrollment or spending, and 12 states reported planning to adopt new waiver service limits to constrain costs. And new caps on the number of waiver participants and spending for specific types of waiver services per participant are the most common, with 8 states planning to adopt each new mechanism. Next slide, please. Looking specifically at waivers serving people with intellectual and developmental disabilities, we see that 9 states reported any new caps on enrollment, spending, or services. And as you can see in the table, only a few states, ranging from 1 to 3, reported using these specific caps and limits that are included. And Wyoming and Michigan were the only states that reported more than one new cap. And although not many states reported adopting these new mechanisms for state fiscal year 2026, this may change as states navigate the reduction in federal Medicaid spending over the next few years. And I also want to note that although it doesn't exclusively serve people with intellectual and developmental disabilities, Oregon also reported in their waiver number 2386 that serves various populations, including children with intellectual disabilities, developmental disabilities, medically fragile children, and children with physical disabilities, that they would have a new cap on the number of waiver participants. So wanted to make sure I noted that as well. Next slide, please. So we've included links to several of our resources at KFF on the effects of the reconciliation law and home care on this slide. And I specifically wanted to note the survey archive link. That's the second to last one on this page here, where you can find our final 3 2025 home care briefs when they're released in January. And you can also find all of the HCBS surveys that we've released in the recent past years on there, in case you want to see data from other years as well. Next slide, please. And we want to say thank you for the opportunity to share our research with you all. And we're really delighted to be here today with everyone. And so we welcome any questions you have for us for the Q&A portion of today's call. And if any questions or there's anything else you want to follow up on, we've included Alice's email on this slide. So feel free to reach out at any point. Thank you.
Okay, thank you very much. It was very informative. We really appreciate your time. We ask folks to hang in there because we have some questions and answers that we're going to do. We've got about 20 minutes to do that. So let's see. We've got one from Jonathan Taylor. Jonathan Taylor is the executive director of the DD Council in Arkansas, and his question is around waiting lists and people who live independently. Jonathan, do you want to ask that question? And Eric, can you unmute Jonathan Taylor to ask this question?
Thank you. Great presentation. Thank you so much for spending the time to share this with us. My question was, how will the waiver caps and waiting lists affect people who already rely on HCBS to live independently? And then what protections are in place that you're aware of to prevent people from losing services or being forced outright into institutions?
Okay, that's a great question. Folks from KFF?
We really don't know because nothing has actually happened yet. And it's also going to depend on the state and what the state does. So if there is a new enrollment cap that just is capping new entrants, then one might envision people who are receiving existing services would be protected. If the new cap is lower than the number of people who are receiving services, the state's going to have to make some decision of what to do with the existing recipients in excess of the new cap.
Thank you.
Okay, thank you. I see Kevin Nunez has raised his hand. He has an accommodation because he cannot type his question in the box. So, Kevin, I'll get to you in a second. Next, there's a question from Sean Schrum. Sean, if you're on, we can unmute you. Sean's question is around tribal organizations. Sean, are you on? And if so, would you like to ask your question to the group?
I'm going to give you the option to unmute in a second. Sean Schrum.
All right, thank you. Yeah, tribal organizations are guaranteed prepayments, and they haven't been receiving prepayment from this administration or reimbursements. Do you have any specific information today on how tribes might be affected? They're experiencing cuts, and staff and services, and specialists are being reassigned all around the country, and they're being separated from the communities that they specialize in. Thank you.
Thank you, Sean.
Sorry, our survey didn't cover that topic, but that is, we were not aware of that, so thank you for sharing that.
Okay, thank you. Okay, Kevin Nunez from New Jersey. You have a question?
Yes, great presentation as always. With the home and community services optional, how can people with disabilities and their families stay informed, be heard, and participate?
So I would say that that's probably a good question for NACDD to respond, unless Alice or Mace, do you have? Okay. So I would say that for people with IDD and their families, support circles, it's always important to participate, to get involved. Our DD councils are a great place to start. You can go to the nacdd.org website, and there's a drop-down menu to find information on the DD council in your area, to be able to get involved in being heard. I always recommend that that's the best place to start initially, and the councils can refer you out, can help get you involved, can help coordinate, and we'll listen and try to understand what folks' concerns are, and pull that information together to help folks move forward and get their voices heard and express their concerns to our elected officials, and also get your concerns and heard on a broader scale, out in the community, not just to elected officials, but so that the public can understand what concerns are and what's really happening for people out there. So reach out to your DD council. You can go to nacdd.org, and there's a drop down to find a council near you. Let me look here in the list of questions. We've got quite a few here now. Let's see. So we have one from Georgia, from Darcy Robb, and I think I saw that your hand was up, Darcy. It's a question about if someone has a waiver and the potential of losing it. Can we unmute Darcy to ask a question?
Hey, thanks, Jill. Thank you both so much for being here. This is great information. My question was, so my understanding has always been that once a person has a waiver, yes, services can be capped, but the only way they can lose that waiver is if the state does away with that waiver entirely. But is that accurate?
Can you ask it again? So that you're saying that it's your understanding the only way a person can lose their waiver if they already have a waiver, services through an existing waiver, is if the state ends that altogether, that program altogether. Am I correct?
Yes, that's what we have been told multiple times by our state DD agency. But now I'm wondering, is that actually true?
We don't have any information to suggest it's not true.
Thank you. Okay, let's see. Let me go back to the questions here. And we also had questions that came in through registration. So let's see if any of those. This one came from Charlie Miller in Georgia. And it is, how will these affect states that did not expand and already have work requirements in place?
So for work requirements in Georgia in particular, it is unclear whether they will be able to keep their exact waiver in place or whether they'll have to modify it to come into compliance with the new guidelines from the law. We're still waiting to see.
Okay. We have a question from Paul Salino. It says $911 billion over 10 years represents what percentage of the total spending over the period?
Sorry, that was the 14% of the federal spending.
Okay, great. Thank you very
And
much.
you can click on the map if you want to see what percentage of your state spending is affected.
Okay, thank you very much. Let's see if we have. Shasta Cairnsmore, are you on? You have a question about that this is confusing to you. So can we unmute Shasta to maybe get some clarification? If you can give us your question or your comment, Shasta, I appreciate it.
Hi, thanks for letting me ask my question. I'm just confused why states aren't just taking the cuts from HR1 and directly applying them to the state budget. Why don't we just cut the provider rates, cut the hospital reimbursements, cut SNAP? I'm not advocating for that, but I'm just saying, why aren't we drawing a straight line? Why are we looking at HCBS?
So every state will respond differently. And some of the cuts, so the work requirements, for example, that's not really a state budget problem because it means the state will not be paying for the person's coverage either if the person's lost Medicaid. And so then you get to the situation of what happens to this person. Is the state going to try to do state-funded coverage because they believe in having people have health insurance, or is the uninsured rate going to increase? And if the uninsured rate increases, then is the state going to try to say, okay, hospitals can absorb that cost, or are they going to try to divert additional money to hospitals? So all of this is, each provision affects things a little bit differently. And every state's going to respond completely differently based on the values in the state, their legislators, their legislative processes, and also which effects are most important. So in a state that has a lot of immigrants and has a lot of people enrolled in ACA coverage like Florida, the Medicaid cuts may not even be the biggest factor here that's going to affect Medicaid home care. Instead, it's going to be whether the state needs to respond to new shortages of home care workers and large increases in the number of people without health insurance from the ACA market. Does that help?
Hopefully that helps. Okay, let's see. We have a question from Tally Wells. Who should we be following or talking to as we get closer to the 2026 and 2028 election about legislative fixes for the worst impacts of HR 1? Ooh, that's a complicated question. Do you feel like that's something you would answer or us? Yeah, I think
That's
that's a
squarely out of KFF
yeah, that's
territory.
not a
So
understood. So I would say, Tally, that is a question for NACDD and our policy department, and we're happy to help you with that, of course, at any time. Reach out. Um, let's see. There's one about expansion population. We already talked about that. Let me see what else we have. Sorry, there's many to read through, so give me a second to try to catch up. From Giassi Burks Abbott, there's a question. Do states use the caps to keep home care from costing more than institutional care? That strikes me as part of the institutional bias.
yeah, that is the requirement. The requirement is that home care can cost no more than institutional care.
Mhm.
Yeah, I guess I'm wondering if we remove the institutional, because that seems to me that's a artificial constraint. In other words, it seems like the state is going to have to bend itself to make sure that it costs less than institutional care. That seems kind of perverse. I don't know. It seems problematic.
I hear what you're saying, Giassi. Okay, let's see. Sorry, scrolling back through the questions. Okay, from Brandy Kuhn, this is more of a big picture question. I'm curious about the potential nationwide financial implications if Congress were to eliminate wait lists for HCBS and or long-term care programs across the country. I recognize this may not align with the current political climate, but I value your perspective as an expert in this area on what such a shift could mean from a fiscal and system standpoint.
So so I'm going to put on my old hat. I used to work at the Congressional Budget Office where I was asked this question by members of Congress, ironically from both parties. There was surprising bipartisan interest in this answer. Nobody likes waiting lists. The real problem is how do you actually do that? One of the things with the waiting lists is the easiest way to get rid of the waiting list is to stop offering the program. And so if we were simply to prohibit states from having waiting lists, I think we might have a scenario where states stopped offering the programs. That would probably actually reduce federal spending, but I don't think that is the goal a lot of people who ask this question have in mind. Alternatively, we can make HCBS a required covered benefit. The problem there is what is the required benefit and how does this happen in such a way that we don't lose the flexibility, the nimble delivery models that states have adopted when you start going to everyone is given access to the same benefit. So I haven't seen a proposal that has solved these kind of thorny issues. So we don't really know how much it would cost.
Thank you. And we have a question from Tammy Jackson. As states make changes, well, actually, is Tammy, are you on? Would you like to ask your question? I'm not sure if Tammy's still on. Okay, I will
Yeah,
ask.
I'm here, Jill.
Oh, okay,
Sorry,
I'll
I gotta
save your reading.
track through the
Thanks.
participants to find who to unmute.
okay.
Yeah, I'm just wondering, as states start making changes, and this will, I think, happen over the next few state budget cycles, as to who can get in or what services are offered or changed in HCBS waivers, will KFF be tracking some data points that will help us tell the story of how many people are losing supports, ending up on waiting lists, or ending up in institutions instead of HCBS, and how can councils be helpful to KFF in tracking state level changes and impact?
Excellent question.
So there's some data KFF does track. One of the things I will say is I think everybody has different roles and KFF's data in some respects are a little bit lagged. So, for example, we're talking about our survey data right now, and those are changes that have already been enacted. And so, if the goal is to have information about what states are considering, organizations such as yours are probably going to be more effective at that than us. We look at the number of people who are using HCBS, but we use claims data from the federal government to get the actuals. Those are also terribly lagged. We are still waiting for 2024 data. And so I think one of the things that KFF is very effective at is when there are data available from different states, we can do a good job of synthesizing and pulling it together to create a repository. But we are somewhat limited if there's no underlying data available. To the extent that your members can provide data, make data available, I think KFF that can help us become a more effective organizer of the data, if that makes sense.
Thank you. That's really helpful. Okay. I'm trying to see if there's any other folks in here that from Laura Halverson. With potential Medicaid reimbursement rates to hospitals coming due to HR 1, what is the likelihood hospital systems like the UT hospital systems no longer accepting Star Plus waiver MCOs like Molina, who I've heard is in a contract dispute right now with the UT hospital system? So what's the chance that that hospital systems like UT will no longer accept MCO payments?
It's just so hard. We've never before experienced cuts of this magnitude, and that makes it really difficult to know how states are going to respond, how are providers going to respond. Is this a threat trying to pressure the state to find a way to give more money, or is this actually going to happen? I think it's really too early to say.
Thank you very much. So we've got 2 minutes left, and with that last 2 minutes, I would like to thank KFF for working with us on this, for being here and speaking today, for being willing to answer questions and to share information and to bring forward data that isn't available yet. I really, truly appreciate that. I also want to thank our team here at NACDD. Your work is very much appreciated. Everyone on staff, of course. And I want to call out somebody whose face you didn't see today, but who is super engaged and really helps make all of these wheels turn when it comes to policy. And that's our NACDD Policy Director, Erin Prangley. Erin, thank you very much for making this happen, for building these relationships with KFF, and for getting this off the ground. And I'd like to thank our operations and admin support team as well. And of course, our board of directors. Thank you everyone for being here today. Thank you, KFF. Guys, we'll get this transcript out after KFF's report comes out in January. So look for that report, and we will get everyone who attended or registered will get this transcript and recording today. Thank you all for being here. We are actually ending at 5. That's amazing. Bye, guys.